Hello there, how you doing?
Zooming into
Oh, that's a bit of a phone, isn't it? I'll turn the camera off when we get going, just to make sure that people know that we're here. I'll enter. Hi, can you hear me, those of you who are online?
Yeah, we can hear you.
Great. So it's just us here at the moment. Don't know your name, sorry.
Mohammed.
Mohammed. So it's just Mohammed and I here in Boston at the moment. I'm hoping a few more will come in. I'm presuming it's just you're just there individually rather than are we logged into Lincoln County?
Lincoln should just be setting up.
Okay, great. All right. Do people normally start at 2 o'clock on the dot, or is it normally take a few minutes for allowing everybody to arrive who's going to?
No, I would give it a few minutes just to allow any latecomers to arrive.
Fine. Okay, we'll hold on for a few minutes then.
Thanks. I know Lincoln tend to be a few minutes late joining, but they should at some point.
Okay. Looks like we're starting to get a few more people here, so I'll just give it another couple of minutes and then we'll make a start. Hi everyone, I think we'll have a go at making a start if that's okay. So my name's Adam, I'm a palliative care consultant. I work at St Barnabas Hospice in Lincoln and then I cover here in Boston 2 days a week. So I'm here around on the wards Mondays and Thursdays. I was in the hospice in Lincoln this morning, but I've come across here to Boston to do the talk. So I think it's always better to try and do these sorts of things in person if you can. I appreciate some of you are online, some of you here in the room, and maybe some people in the room in Lincoln, although I can't see whether that's the case or not. But I'll make a start. So I was asked to teach on, well, it's a slightly, on acute on palliative care. But a sort of a range of different things within that, some of which aren't actually anything to do with palliative care. So one of the topics that's on your curriculum that seems to have got put under palliative care is unexpected death. And clearly if it's unexpected, they weren't palliative and we've had nothing to do with them. So I don't know kind of why that has been put there. But I've sort of negotiated what I would talk to you about, and the decision was that I will talk to you about symptom management, particularly around the end of life, talk to you a bit about end of life care and a bit about communication skills. So I'm not going to do a sort of basic, how to do a breaking bad news and, the 11 steps or whatever it is. I think you've probably had all of that by now and are probably pretty good at it. So I'm going to do that bit in terms of a few cases, go through some case histories and get you to think and respond. I need people online to be able to kind of interact with that as well if possible. So ideally, if you're able to put cameras on, so when I flick to you, I can sort of see who's there and try and get you to be involved. It's not going to work particularly well if it's just me talking, and if it's just me talking and the people in the room keep getting picked on, then that's a bit unfair. So it's best if we can get you to unmute and get involved as well if you can, because I'm trying to make you think a little bit, not just sort of pile a load of information into you. So that's the idea. Do feel free to just unmute and shout out and interrupt whenever you wish to, and I'll try and sort of involve people as much as possible. I'm going to share the screen so you can see which presentation I'm on, but obviously when I'm doing that, I'm not necessarily going to be able to see hands up and things like that, so do just interrupt when you need to. So I'll put the screen share on. Entire screen is usually the best way of doing it. Okay, so hopefully you can see what I can see, and if I put that up. So I'm going to start with talking to you about symptom management. So this is the one that is a bit more sort of didactic, but hopefully you'll be able to follow along and chip in where necessary. Can I just check that you can see the presentation? You can see on screen what I'm looking at.
Yes, we can.
Yeah, we can see that.
In that case, I will make a start. So, what am I trying to cover here? So there's some general principles around end-of-life care and symptom management. I'll talk about the common symptoms that we come across at the end of life. There's a three-step approach in palliative care to symptom management. And I mentioned a bit about anticipatory prescribing, so planning ahead. And I'll look at specific symptoms, so pain, breathlessness, agitation, nausea and vomiting, and secretions. And they're the ones that you do anticipatory prescribing for, and they're the ones that we most commonly see. So the symptoms that we see at the end of life are pretty similar despite the diagnosis. So whether we're talking about somebody with advanced cancer, somebody with organ failure, so heart failure, end-stage COPD or interstitial lung disease or whatever, or whether it's degenerative neurological conditions, we tend to see a similar list of potential symptoms that people have. And the main ones, as I've already said, pain, breathlessness, agitation, nausea and vomiting, and secretions, and they're the ones that we tend to do anticipatory prescribing for and plan ahead that we're going to see those. There are other things that we see, so fatigue, reduced mobility, increasing dependence, those sorts of things, drowsiness. And they tend to be more markers of deterioration. So they're the things that tell us that a patient is deteriorating and that time is getting shorter. Not necessarily an awful lot that we can do. There's no drug that's going to fix those. There are things that we can sort of tinker around the edges with, but there's a limit to what we can do to fix those things. We tend to see things like dry mouth and reduced oral intake quite a bit. Again, they're signs of deterioration. Dry mouth often more to do with a patient's medications and side effects and so on, rather than dehydration as such. And then there are sort of nursing care issues like mouth care, and then urinary and bowel management, skin care issues, those sorts of things, pressure areas and stuff. Okay, I do apologise that the formatting goes slightly odd. This started off as a widescreen presentation, but when you come to some computers, and this is one of them, it reformats it all, and so if it's sort of printed slightly off the bottom, that sort of thing really irritates me in presentations. And it was right when I looked at it yesterday, but obviously it doesn't quite fit the way this is formatted it. So, as I said, there's a three-step approach to managing symptoms in palliative care, and which is more important depends on sort of where people are in their journey. So if people are reasonably well, up and about, might have prognosis of months or more, then we're really looking for correctable causes. Why have they gone off? What's causing that symptom? Is there anything that we can correct in there? And I'll talk a bit about some of the correctable causes for different symptoms, but we're certainly looking for anything reversible, and that's the main sort of stay. And then as that prognosis gets shorter, we do still look at correctable causes, and that's still important. But then we're starting to look at more around whether there's non-drug measures or whether there's some drug treatments to try and manage those symptoms. As people deteriorate further and get towards the final stages of their life, then there may still be something correctable in there, but we're less likely to be able to correct it, even if they've got a chest infection, for example. Will they be able to fight it off? Is treating that infection appropriate, or would that just be sort of prolonging things? Is it better to focus more on the symptom management side of it? And drug treatment becomes a more important part within that. So don't forget the other things, but as people get closer to the end of life, we tend to focus more on the medications. Okay, yeah, again, it's reformatted all of this, which is really irritating. So I do apologise for that. I like a nice clean lines and a nice presentation. So anticipatory prescribing, this is about thinking ahead. What symptoms might the patient get? Sometimes people will say, well, do I need to do anticipatory prescribing? And it's like, well, the patient's got advanced disease. You've contacted us as the palliative care team to get involved. Could you anticipate that with their advanced cancer, they might start to struggle with breathlessness, or they might start to have some nausea and vomiting? I was like, oh yeah, well, there's lots of reasons why that could happen. Well, in that case, you can anticipate it's happening, so you should have this sort of stuff prescribed. We don't have to wait until we've stopped everything else. So it's not this binary idea that you're all active treatment, you're giving antibiotics and fluids and stuff, so you can't do the anticipatory drugs yet because you're not ready for that yet. And then you stop everything else, and that's when you're allowed to prescribe it. It's much more seamless than that. We should review every day, every patient, to think about what medications are they on. Is there anything that they're on that we should get rid of? Is there anything that they're not on that they might need that we should plan ahead for? Are the treatments that we're offering, if they're here in hospital, for example, are the treatments that they're offering appropriate? Are they working? Do we need to change them to something else, or do we need to stop them and move to a more sort of symptom management approach? So the symptoms that we need to manage, anticipatory drugs, we use opioids for pain and breathlessness. We use midazolam or benzodiazepines for agitation, also for breathlessness as well. Levomethrazine is for nausea and vomiting, so it's a broad spectrum antiemetic, but also it's an antipsychotic, so that is also helpful for agitation. And then hyoscine, which is a hyoscine butyl bromide version for secretions. They're all subcut, and they can all be prescribed up to hourly or 2 hourly. We routinely prescribe everything hourly in the hospice. I know here there's a bit more of a compromise with here in the community, so we tend to go sort of 2 hourly. If you're making people wait 4 hours for another painkiller, that's probably not right. It's not fair. They don't. You know, if it's only partially working, they might need sort of more frequent doses than that. And what tends to happen is sometimes people will need 2 or 3 doses fairly close together, and then it'll build up and they'll settle and they'll be all right for several hours after that. And then we need to think about what we're giving them regularly. So they all need to be available in the home and also on the CD1 form. So if we're discharging people out into the community or to a community bed, in a community hospital, then we need to make sure that those anticipatory drugs go with them, and the CD1 form, which is what the nurses then administer them against. That's the gold form that I'm sure you're familiar with. I put anticipatory syringe drivers on there. So we sometimes get asked to write up a syringe driver just in case for when the patient needs it. And we will often get phone calls from the community to say, what would you write up? I say, well, what symptoms have they got? Well, they haven't got any at the moment, but they might get some. I was like, well, I wouldn't write anything up. So my answer to that, and the answer that we sort of tend to have as a palliative care team, is that anticipatory syringe drivers really don't have much of a place. There's not much evidence for them. And when you sort of listen to national conferences and things like that, their advice is very strongly to say, I wouldn't go down that route. That doesn't seem appropriate. It's one of the things, you're familiar with the Gosport inquiry, where there was a community hospital in Gosport, where a doctor was doing lots of anticipatory prescribing. Patients would be admitted really as a community bed for rehab and things, but they all got syringe drivers written up. They all got anticipatory drugs, really at big ranges with lots of different drugs in there. They may or may not ever need, and lots of things got started, and then people died because we're giving them lots of drugs they don't need. And so actually, you know, that was quite a scandal. So we're going to need to be really careful with that sort of thing, because that's the kind of route that was going down. So to my mind, anticipatory prescribing for PRN doses, they might need a painkiller, so we'll have it written up in case. That's great. Anticipatory prescribing for a syringe driver, so for something regularly when we don't know what they might need, we don't know which drugs they might need or what doses. So we're then writing a range of stuff up for a non-prescriber, the nurse in the community, for example, to then make their decisions at a later date with your signature at the bottom of it. Is not safe prescribing standards, that's not great. So what we should be doing is instead allowing them to have doses of what they need, and then when we're ready to prescribe something, they should be reviewed, ideally reviewed in person by a prescriber, but if not, then at least by the community nurse or whatever, who can say, right, this is what they've had in the last 24 hours, these are what doses they needed, this is whether it's worked or not, this is how they're tolerating it, so we can make an informed decision on what goes in the driver. And we get advice calls about that sort of thing all the time. So make a decision at the time and then prescribe or advise what you think should be prescribed is much more better than trying to plan ahead with the syringe driver. Oh, I hate it when it goes all formatting all wrong. Right, so going through the symptoms one at a time then. So we're thinking about pain first of all. So again, correct the correctable. If their pain is due to constipation, then more and more morphine is probably not going to be the answer. So thinking about what's causing it and is there anything reversible in there. Again, if it's a chest infection that's causing their pain or a PE, then there are treatments for that are going to be more effective than with painkillers. Then thinking about non-drug measures, not forgetting that non-drug measures have a role in this sort of stuff. And then if we're talking about analgesics, we've got the analgesic ladder. So step 1, paracetamol and a non-steroidal, if we can tolerate one. Step 2 is weak opioids, so codeine. And then step 3 is get rid of the weak opioid and move to a strong opioid, morphine, oxycodone, fentanyl, those sorts of things. Increasingly in palliative care, we don't really use step 2 because why would we? We know where we're going to end up. So for things like cancer pain, we would be moving straight to a strong opioid. And then there are adjuvants, things like gabapentin, amitriptyline, steroids. So that far is what we would expect you guys to be able to do independently on the wards, in the community, and probably wouldn't need our help with that. We do often get asked to come and see a patient, so get a referral for a patient. They're saying they're in pain, and we get there and they're having paracetamol and nothing else. And so they haven't, or they've written up some PRN oral, but nobody's really given them any. And they haven't been able to then take that next step of moving up the analgesic ladder. So we'd expect you guys to be able to do that sort of thing really. There are cases where people are very sensitive to medications and other reasons why it might be more complicated, but generally we would expect to be sort of called in at this point where we've tried all of those things and we're sort of struggling to get on top of things. Other things that might help, some evidence for benzodiazepines, things like clonazepam, there's evidence for diazepam. Bisphosphonates for bony pain and bone mets. Things like radiotherapy, nerve blocks, you might need specialists involved to deliver those sorts of things. And then there are other things which I'll come on to a bit. Things like opioid switching, so switching from one type to another, using more specialist stuff, so methadone, ketamine, we're now using clonidine as well. And those are things that we'd use in the hospice, so they need to be admitted under us to do that. And then when we're heading towards end-of-life care, then there's a balance between pain relief and sedation, and perhaps adding a bit more of that in. Right, so morphine is the strong opioid of choice. It's the one that people are most familiar with, and therefore if you write it up, it's more likely to be given. If you're writing up to something weird and wonderful that nobody's heard of, the pharmacist won't have it, they won't deliver it, and the nurses on the ward won't give it because they're not familiar with it. That is a problem to a certain extent with oxycodone and fentanyl because people are less familiar with it, so they're less likely to have it given. But we're getting more familiar with those, and I think they're generally okay. But certainly morphine is usually our first choice. It's a mu opioid receptor agonist, so it's not an antagonist, it's not a blocker, it's an agonist, so it stimulates the inhibitory nerve. So you've got your primary neuron that goes from your tissues peripherally up into the spinal column and synapses there, and then you've got secondary order neuron that goes from there up to your sensory part of your brain. And where that synapse is in the spinal cord, there's an inhibitory neuron that sort of sits in that gap. And what that does is it modulates how much of the signal can get through. So we often talk about the gate theory. So it's how open or closed that gate is, how much signal it's letting through. So what opioid agonists do is that they stimulate that, they agonize that inhibitor to close the gate. Okay, so that's how it works. The bioavailability for morphine is not great. It's about 30%. We tend to work on a kind of 2-to-1 conversion when we're going from subcut or IV to oral. We sort of double the dose or harder if we're going the other way. But actually, the bioavailability is variable between individuals, but it's probably only about a third. There are two main active metabolites, so morphine 3 and morphine 6 glucuronide, which they're active metabolites, so they have effects on the body themselves. And so as the morphine is broken down, you've then got active metabolites that are floating around, sometimes causing trouble, and particularly in renal failure. So if you've got renal failure, that morphine 6, the half-life of that trebles in renal impairment. And therefore that builds up and causes some of the side effects that we see. When people are over-opiated, so they're drowsy, sedated, and possibly respiratory depression, that tends to be things like morphine 6 that are building up. So if somebody was stable on their dose of morphine and they've been fine, and now suddenly they're over-opiated and you haven't increased the dose, the likelihood is that we need to check what their renal function is doing. And then some of the hyperexcitability type side effects, which I'll mention in a moment, are due to the other one, so it's morphine 3. Okay. So side effects of morphine, there are common initial side effects, so drowsiness, nausea and vomiting, unsteadiness and confusion. So those are the acute ones that you might see when you start a dose and when you increase a dose. If you can get people through that first couple of days, they may well settle down. So what we've got to be careful of is that we then give one dose of morphine, somebody feels a bit nauseous or is a bit drowsy on it, and then we write it off as something that they can't tolerate, and suddenly morphine and all opiates are now off the table. That's not great, really. We might need to just be a bit more patient than that and see if we can get them through that first couple of days, and it should settle down. The ongoing symptoms, the one that they will need something for, is constipation and nausea and vomiting. So everybody on a strong opioid needs a laxative, unless they've got some other bowel problem that's making them too loose. The chances are most people will need a laxative co-prescribed, and everybody should have an antiemetic prescribed as needed. You may not need it after the first few days, it may settle down, but they should have it prescribed as needed. And then more occasional side effects, things like dry mouth, sweating, itch, urinary retention, and then these hyperexcitability, so there's these neurotoxicity type things. So that can be things like hallucinations, myoclonus, allodynia, so that's pain from what would normally be a non-painful stimulus, so light touch or your clothes on your skin can cause pain. Hyperalgesia, so that's pain out of keeping with the stimulus, so a painful stimulus, but not one that should feel as bad as it does, or pain from a different area, so they're recruiting fibers from other parts. And then delirium. So all of those are these neuroexcitatory side effects. And again, that can be a sign that people are over-opiated, or that they have gone into renal failure and some of the metabolites are building up. And then the rare ones are things like respiratory depression and psychological dependence. So respiratory depression is the reason that doctors are always wary to give morphine. You know, they've got COPD, I can't give them morphine. It's like, well, actually you can, and we do all the time. And then psychological dependence is addiction. So that's the reason that patients don't want to take morphine, because they might get addicted to it. And actually that's very rare. If you're using it appropriately and titrating against pain and using slow release doses of things, then people getting addicted to it is really quite an unusual phenomenon, not something that we tend to worry about. So often we're reluctant to use opiates and to escalate up to strong opioids, but actually, you know, it's the reasons that we're worried most about them are quite unusual. I will mention respiratory depression because we quite often see people who've been given naloxone somewhere along the line. And we've got one in the hospice at the moment who's given naloxone and probably shouldn't have been. And we often see naloxone overused. So what's the indication for naloxone?
reduced GCS?
No.
Apnea or
Yeah, so reduced respiratory rate. And what respiratory rate are you worried about?
below 8?
Yeah, so below 8, respiratory rate below 8, or the consequence of that, so hypoxia or hypercapnia relating to their opiates is what naloxone is indicated for. It's not indicated for drowsiness. It's not indicated for pinpoint pupils. That just tells you that they're on an opiate. It doesn't give you any other information than that. It's not indicated for confusion or any of these other side effects. What we would do for that is omit tonight's dose, reduce it from tomorrow, check their renal function, think about prescribing a different opioid, but we'll let them sleep it off. So, okay, so you don't need to, just because they're drowsy or even unconscious, as they're breathing, then that's fine. You might monitor them closely to make sure they do carry on breathing and don't get respiratory depression. But if you've given somebody who's got chronic pain and who has a long-term opiate, and therefore their opiate receptors are sort of saturated, and you give them an agent to reverse that and block it suddenly, you put them into withdrawal, so you put them into cold turkey. It's a really unpleasant thing to do to somebody. You're giving them pain because you're, suddenly activating all of their pain receptors again, let them down. You cause a huge adrenaline release. You can cause pulmonary edema. You can cause arrhythmias and MIs and things like that. So there's a patient safety alert out that says don't use naloxone unless they've got the indications for it. And I worry about that. I think we use far too much of it. I mean, to my mind, it should be a kind of almost a never event that needed to use naloxone, and it should be investigated every time. But the number of times that we see, the med-reg came by and just said they're drowsy, so they gave a bit of naloxone, and it woke them up. Now, can you come and help sort their pain out? I said, no, I can't sort their pain out. They're going to have pain for days. It's going to be really difficult. They're going to be agitated. And if they're dying, they're going to have a terrible last few days, and it's really difficult for us to fix that. So, yeah, just be really careful with naloxone. It's far overused, I think. It's got its place, but I think we've got to be really careful about using that in somebody with, with palliative condition is on long-term opiates. Okay, so has anybody come across that term, opioid-induced hyperalgesia? No? It's probably much more common than we realise. When they look at animal models, it's fairly universal, so we've got to be aware of this thing, really. So this is the idea that opioids, people can develop this increasing sensitivity to noxious stimulus. So this allodynia and hyperalgesia. So they are an effective neuropathic pain. So where your nerves are damaged, so you've got tumour pressing on the nerve and eating into it and causing it to fire unnecessarily and things. So you get this allodynia and hyperalgesia. But where you have opioid, and particularly where opioids have been sort of increased fairly rapidly, that can be an opioid side effect. So the opioids can be making that worse. And so what happens is their pain's getting worse, and so we increase the opioids again. And then their pain's getting worse, so we increase the opioids again. And you get into this vicious cycle where it's the opioids that are driving this allodynia and hyperalgesia. So increasing your opioids is a reasonable thing to manage tolerance. So tolerance is where you get gradually better at metabolizing the drug, putting it through excretory pathways, breaking down the metabolites, and excreting it from your system. So over time, because you upregulate these things to get rid of this drug, you need a higher dose to get the same effect. And as long as you increase the dose and your pain gets better again and you tolerate it, that's fine. The problem with this is where you get increasing sensitivity and this allodynia hyperalgesia thing. And as we increase the dose, actually their pain's getting worse. That's quite difficult sometimes, and you might need to have specialist advice involved in helping with that. It's very difficult if somebody's pain is getting worse and we come in and say to them, it's your painkillers that are making your pain worse. In order to help your pain, we're going to reduce your painkillers. That's quite a difficult sell. So you might need some help with that. But the bottom line is, if what you're doing isn't working, you need to think about something else, and you might need some help if you're not sure what's going on. But just, you don't have to remember all of that, but just to be aware that there is this thing out there that can be a reason why people are struggling with managing their pain. Okay, so thinking about opioid switching, so there is no evidence that morphine or oxycodone are better than one is better than the other. We tend to use morphine first because it's cheaper and because people are more familiar with it, but that doesn't mean that then we escalate to oxycodone because that's the better one because it's more expensive. They did a study where they put people in each group and started with either, and about 2/3 of people responded to whichever opiate you started them on. By respond, that means that we can titrate the dose up to a level where their pain is reasonably well managed. About 30% of people thereabouts won't respond to whichever one you start them on, either morphine or oxycodone. And that means you either can't get decent analgesia from it, however far you titrate the dose, or they start to get side effects from whichever one they're on, and they can't tolerate it anymore. So there's a good rationale for switching to the other one, whichever one you're on, switch to the other one. There's a variation in individuals between different opioids, but about, again, 2/3 perhaps will respond to the other one. So there'll still be about 1/5 of people or 6 people at the end of it that don't respond to either of them, and they're the ones that we tend to say are kind of non-responders to opioids. But whichever drug you switch them to, a decent number of people will then respond to the new one. And the reason for that is because opioids are, like any drug, go through this whole pharmacokinetics and pharmacodynamics. So they get absorbed, they have to cross membranes, they get through the liver, they get partially metabolized. Some of it will not be metabolized, and for use, some of the metabolites will also be effective. You have to have receptors for the opiates for them to work on, and then they'll be broken down and excreted, and each of the breakdown products will also then need to be excreted separately. And all of those things that happen to a drug are all controlled by our genetics. And we all have these things called single nucleotide polymorphisms, which mean we have different genetics. So my genetics for handling morphine are going to be different to yours. And it might be that I handle morphine pretty well and I've got lots of morphine receptors and can excrete morphine, so I can tolerate it pretty well, and it works well for me. You might not have any of those things. You're sort of quite deficient in morphine receptors. You're not great at metabolizing morphine, so it tends to build up and gives you more side effects. But oxycodone might be right up your street. That one will work really well for you. You'll get a much better effect from that than I would. The problem is we don't know who's who. We don't know which way around that's going to be. Hopefully one day we'll be able to kind of do a blood test on day one, and then we'll work out, yeah, you're going to be a morphine person, you're going to be an oxycodone person, and we'll kind of start them on that. At the moment, what we have is we try one, but if that doesn't work, there is a rationale for switching to the other one. So there is some benefit in opiate switching. So just going up and up with one might not be the answer. It might be better to switch into a different one. If we're going to switch, we need to think about which one. And again, all of these arrows and so on have reformatted themselves because it's the wrong size screen. So we have, if it's CNS side effects, and we're started on morphine, we would normally switch to oxycodone. Oxycodone seems to suit people better if they can't tolerate the drowsiness and confusion, hallucinations, that sort of thing from morphine. If it's that they can't manage their tablets or they're not very compliant with taking them, then obviously fentanyl, because it's given through a patch. Constipation, fentanyl is much less constipating. Proportionally more of it ends up in the brain, the white matter where it needs to be. It's very lipophilic, and less of it ends up sort of affecting the gut and causing sort of nausea, vomiting, and constipation. If opiates are ineffective, then methadone might be more helpful. And then if it's renal failure, then either fentanyl or alfentanil, depending on whether it's a patch or a syringe driver that you want, tend to be the ones that we switch to. Whenever you're switching an opiate, you should normally think about dose reducing at the time, because what you get is your tolerance. So you might build up a tolerance to morphine. As I say, you've sort of gradually kind of upregulated your receptors. You get good at breaking it down and excreting it. So, you know, a 5 milligram dose might knock me out, but you've been on it for years, and therefore, you know, you're on 100 milligrams, and that's fine. If we switched you to oxycodone, we wouldn't start again at 5 milligrams. We'd probably be able to give you an equivalent dose. So there's all sorts of tables that show you what the equivalent dose is of one opiate to another. From morphine to oxycodone, you would normally halve it. So if you're on 100 of morphine, we would think that that would probably be equivalent to about 50 of oxycodone. However, that is if you were completely, that's the dose equivalent as give you the same amount of analgesia. But you might not be as tolerant of oxycodone as you were of the morphine, because that tolerance that you get from one, you get cross tolerance, you're also tolerant to the other, but not quite to the same extent. So from a safety point of view, you should do your calculation, so you halve it to find out what the oxycodone dose is, and then reduce it again, so reduce it by a quarter to a half. Okay, so you might, again, need some help. If you're doing high dose opiate switches, we tend to be quite cautious with reducing the dose. And then they might need more PRNs for a few days. You might then need to titrate the new one back up to whatever the equivalent level was. But we often do that. And you might want to vary it depending on if you're switching because they're just not getting analgesic from it, but they're tolerating it fine and having loads of PRNs, then you can probably be a bit more generous with the dosing. If you're switching because they didn't tolerate the morphine and they're getting loads of side effects, then you probably want to dose reduce by a bit more to be on the safe side and be a bit more cautious. Okay. Any questions on pain at all? Again, shout out if anybody on the screen wants to ask anything about pain before I move on. Okay, so we'll talk about breathlessness. So again, this three-step approach: correct the correctable, non-drug measures, and then thinking about the drugs. Oxygen, obviously, is a drug, and then morphine, benzodiazepines, and I'll talk about sedation. So non-drug measures, obviously there's lots of reversible things that you can find out and teach you how to look for infection and so on. But non-drug treatment, so some of this is about expectation management. So people are quite frightened of breathlessness and think that they're dying, and they have a sort of panic attack, and they get this panic cycle where they get lots of adrenaline released, and then they kind of get all palpitations and feel kind of really unwell. And then eventually that adrenaline will sort of burn off and they'll run out and they'll settle down and their breathing will sort of resolve back to normal. It's often set off by an episode of exertion or talking or emotion or something like that. And so these episodes of breathlessness, you might have baseline breathlessness, but episodes of exacerbations on top of that, and helping people to understand what's happening there and that you didn't die in the last one, you're not going to die in this one, you're not going to die in this acute panicky episode. So that reassurance, understanding of what's happening, and perhaps a bit of cognitive behavioural therapy around the effect of adrenaline and how to sort of calm your breathing down and so on can be helpful. So maximising feeling of control over breathlessness, so having a plan for an acute episode. So if step one, if you imagine a COPD patient who gets an episode of breathlessness, if step one is I'm panicking, I'm dying, I'm going to ring an ambulance, then they end up in a corridor in A&E for hours. By the time they get seen, all that adrenaline's worn off. Now, when I was at your stage, we used to see them in A&E. Oh, hello, Mary, nice to see you again. Sort of all settled down, hasn't it? Let's get you back off home again. You don't really have the option to do that anymore. People are, because of the 4-hour wait and trying to get people out of A&E, people are moved to the admissions unit. By the time they're in there, you can't really send them home. You've got to wait for the post-take ward round the next morning. So people get clerked in. Post-take ward round, they'll send them off to the ward, and it's not until they get to their base ward 3 days later that they then get home again. So people end up staying in a way that they never used to. We used to sort of let people settle down. If you had 3 referrals, you'd leave the COPD one to last because you know that they've settled down by the time you get there. They've had some meds and steroids and off they go again. We don't seem to be able to do that in the same way anymore. But instead of step one being phone an ambulance, if you say, right, okay, well, step one is whatever you're doing, whether that was doing dishes or, walking around or whatever, sit down and rest. And then step 2 is look at the clock and do your breathing exercises and do this for 5 minutes. And whether that's sort of rectangular breathing or, just kind of that sort of deep breathing in through the nose, out through the mouth, whatever it is. Step 3 is, stick your nebulizer on. I've got one of those if you're feeling a bit wheezy. Step 4, put the oxygen on. Step 5 might be, give your daughter a ring, and she said, next time she'll pop round and try and help calm down and settle things down. and you still have ring an ambulance, but that's step 9 rather than step 1. And you never get to step 9 because 2 hours has gone by the time you've got through steps 6, 7, and 8, and actually things have all settled down and things have resolved. So that's the control over breathlessness, having a plan, having a sort of written plan for what you're going to do to try and manage that. There are other things like opening a window, having a fan. All of these things, moving fresh air around, fresh air hitting the back of your nose is actually what's more important. It's probably more important than oxygen. And then complementary therapies and other things like that all have a role. So there's lots of non-drug measures you can use for breathlessness. And then thinking about drug, oxygen increases your alveolar oxygen concentration. Oxygen diffuses in through a concentration gradient. So if you increase the amount there, more diffuses in passively, and it makes it easier. So it reduces the work of breathing. It's not really about the sats. So you can have sats of 96%, but you have to breathe 40 a minute to keep them there. And you put some oxygen on and the stats are still 96%. But they're now breathing 20 a minute, and so you've halved the amount that they're able to work. You've made life a lot easier for them. It's not really about the stats so much as the kind of how much work they're having to do to keep them there. Obviously, you're familiar with high flow oxygen and controlled oxygen, so whether or not they're type 2 respiratory failure. You can vary the method of administration. We tend to favour nasal cannulae and palliative care if we can, because they don't get in the way of communication. They allow you to eat and drink while you're on it. And thinking about short burst therapy after exertion. So put it on for a few minutes and then rest and then take it back off again, rather than just sitting on it and becoming oxygen dependent. There is a study that shows that if you have somebody who's breathless and you put them on nasal cannulae, they can't actually tell the difference whether it's oxygen or piped air. So they looked at them and did, half in each group, and the results were the same. And so it's probably about fresh air hitting the back of the nasal turbinates and sort of giving you that sensation of relief is probably more important than the fact that you've actually increased their oxygen concentration of what they're breathing. So that's why having an open window, having a fan, sort of fresh air actually makes a difference. You sometimes have to see people looking at these little handheld fans and like, what good's that going to do? No, actually, have some faith in it. It will make a difference. Okay, morphine, as we've said, is a mu opioid receptor agonist. In breathlessness, what it does is it reduces the stimulatory effects of this glutamate system, which is an excitatory system. So it reduces your response to hypercapnia or hypoxia. So it makes you feel less breathless. It makes you work less hard. It's usually helpful when patients are breathless at rest. If they're breathless on exertion, then by the time they've got the oral morph drawn up and had a dose and it's been absorbed, they've probably settled down and it's gone. So it's probably not as useful there. So what we tend to do is trial a low dose. So I would normally write people up for 2.5 to 5 of oral morph, give them a couple of doses, test it, see whether it works. Did you find that helpful? If they did, then I would start them on a regular dose fairly quickly. I think just having PRN doses, their breathlessness settled down by the time they've got it. So it's usually more just to test the theory and then start them on a regular dose. And usually sort of 5 to 10 of regular morphine is enough. Anxiolytics have a role because breathlessness and anxiety are kind of two sides of the same coin, really. We all know that if you get out of your depth in the swimming pool and take a mouthful of water, you get panicky very quickly, and that's not something you can control. So it's not that people are breathless because they're anxious, it's that people are anxious because being breathless is a really difficult thing to not be anxious through. So benzodiazepines have a role, and then if people have a decent prognosis and are going to be around for long enough to start them and titrate them up, then SSRIs can also be helpful. And then neuroleptics or antipsychotics can be helpful. Things like haloperidol have a role as well. Antipsychotic effect, that can be an anxiolytic. And then thinking about terminal breathlessness, this is something that people are very frightened of as patients, this fear that I'm going to suffocate or I'm going to drown. And having a positive approach is important. So nobody should die in respiratory distress. And if they are doing, that sort of indicates that we're not trying hard enough, or that we've not found the right combination of things, or maybe you need a bit more help. I would be quite generous or aggressive with medications in order to control a terminal breathlessness and get on top of things. And sometimes the problem is people haven't really escalated the doses quickly enough to manage that. So do ask for help if you're struggling to manage somebody with this. So in a syringe driver, things like morphine, midazolam, and then a benzodiazepine, an antipsychotic like levodopa might need to be used in combination. So it's important to think about what we're trying to do here. So we're not aiming to sedate somebody, we're aiming to manage their symptoms, but there is a balance sometimes between comfort and drowsiness. And usually it's worth asking that question. So if you ask somebody, we can give you something to help you feel a bit more comfortable, but it might make you feel a bit more sleepy. Sometimes people tell us they don't mind that and they'd rather be asleep as long as they're comfortable. Other times people say that they want to be awake and alert as much as possible. What do you think? And 90% of people will tell you, I've had enough, I just want to be comfortable. Give me whatever you need to, I don't mind being more sleepy. And when they've said that, and when the family are there and they've heard that, that makes it much easier for you to then be a bit more generous with medication and that things. Okay. So that was breathlessness. So moving on to agitation. So terminal agitation looks like delirium or vice versa. So it's sometimes difficult to tell early on. So you get a prodrome, things like restlessness, anxiety, sleep disturbance. People become a bit irritable, get disorientated. They're not really remembering or concentrating on what you're saying, often very distractible. So you'll be chatting to somebody and they're more interested in what the nurse is doing behind the curtain with the next patient and shouting, well, what was that? Sorry, what were we saying? Oh, who's that over there? Just being distracted by what's going on around them and not able to focus on the conversation that you're having with them. And then emotional affective symptoms, and then sometimes delusions and hallucinations, things like that. So often terminal agitation then becomes sort of apparent over time as people become more agitated as they deteriorate. It's always worth thinking about what's reversible, because there may be a delirium and something reversible in this. It may be even with a terminal agitation, there are still things that we can do that might be reversible. So things like pain, constipation, if they're withdrawing from steroids or alcohol or other drugs, psychological causes. They might have things like hypercalcemia, so that's always worth treating, because dying with uncontrolled hypercalcemia can be quite unpleasant. Urinary retention, again, sort of sticking a catheter in and everything settles down is well worth doing. I think that said steroids and then benzodiazepine withdrawal, but steroid withdrawal either. So either starting or stopping either of those things can cause a delirium and obviously can contribute towards terminal agitation. It can be quite difficult to manage a terminal agitation. These are one of the reasons that we admit people into the hospice. At the end of life, they were managing at home. They wanted to be at home for end of life care, but just become too restless and agitated and difficult to manage. And sometimes that requires quite significant sedation. So stepwise approach. So reversible things we've already mentioned. Non-drug measures, that might be about sort of lighting. People get more confused at night when the lights go down, they become more disorientated. Getting their family involved to come and sit with them is often very helpful. And then using either a combination of haloperidol, so it's usually an antipsychotic and the benzodiazepine in combination rather than one or the other. And then levodopa is a more powerful antipsychotic. That's what I would tend to use if we've got proper terminal agitation. I'd be going in with that. There are things that we can use that are even more sedating than that. So phenobarbital we would use in the hospice. Propofol we wouldn't use ourselves, but anaesthetists and others can sometimes use that. So we will often go up to doses of things like maybe 200 of levodopa and 100 of midazolam in a syringe driver, sometimes split across 2 syringe drivers, plus whatever opiates they're needing. Before we think, right, okay, we're not winning with this, so we might need to add in something else. So that was always sort of phenobarbital up until fairly recently. Now there's good evidence for clonidine, which they use in ITU as a spinal thing. but there's good evidence that that can be good as well as for painkillers as a antipsychotic, as a sedation in terminal agitation. So we might be sort of favouring that ahead of phenobarbital, just because phenobarbital is difficult to use sometimes. But yeah, so do ask for help if you're struggling. So again, with palliative sedation, as I mentioned, for breathlessness, the intention is symptom relief. It's not about knocking somebody out, and it's certainly not about euthanasia, although that's often a question you might be asked about. Is this appropriate? What are we doing here? Are we trying to sort of finish them off early? The answer to that is no, and we need to make sure that we're clear that we're managing symptoms. So it's a stepwise approach. So you might use some PRN sedation, so offering time out. You know, I can see you're really distressed with these symptoms. What we can do is offer you something just to let you get away from it for a few hours, get some sleep, see how you feel when you come around again. And people often feel a bit more relaxed, a bit more settled once they wake up again. If they find that helpful, then putting a bit into the driver is reasonable to just sort of help to get on top of those symptoms and then gradually titrate the dose up. The problem with terminal agitation is it's a moving goalpost. So whatever they need today, they've had this many PRNs, you can kind of see that they're agitated. So you increase the dose, but by the time that's kicked in, they've deteriorated further, and so their agitation has increased, and so you're trying to sort of play catch up. So sometimes it can take a little while, and you have to reassure families that we will get there, we just need to catch up. And sometimes you do that for 2 or 3 days, and then you kind of get on top of it, and it accumulates, and you're able to settle things down. The best thing is to make sure, again, families and certainly patients, if possible, are involved in that decision-making process. They're on board with what we're trying to achieve. Okay, so nausea and vomiting. So we think about the pattern of nausea and vomiting. So is that a large volume vomit, gradually builds up, bring back everything that they've eaten during the day, and then it all settles down and they feel better again, and then that nausea gradually builds up again? Or is it a sort of constant background nausea that's there all the time, never really settles? So that would be the difference between a sort of delayed gastric empty and gastric stasis pattern, where it gradually builds up, they vomit back a bucket full and they feel better, versus that kind of chemical cause of nausea and vomiting, where they've got something unpleasant in their system that is just building up. What triggers it? What they had before, did it work? Have a look in their mouth, just check that there's no thrush or anything like that, because that could be down the esophagus and can cause it as well. And then investigations, again, looking for reversible things. So correct the correctable, again, formatting all over the place. So first place to look is always what's on the drug chart, what are they on? Is there anything there that we can review, get rid of, anything that they don't need? Hypercalcemia is treatable. Constipation, infection, ascites, renal failure, all of these things have kind of particular treatments that you can give. And then things like raised intracranial pressure or pain or other things like that. So there may be other things that we can do to manage that nausea. There's general measures and non-drug measures, things like eating little and often. So if you're faced with a big plate full of food and try and get it down, you might feel sick, but you know, just having a little bit of what you fancy. Start with the pudding if that's what appeals most. You know, allow people to just have a little bit. Avoid sort of fatty foods and cooking smells, odor control, you know, particularly things like elevated tumours and so on. Distraction and complementary therapies, all of that has a role. And then there's something about having a conversation with the patient, with their family there, and explaining that their appetite has reduced, and that's a normal pattern of people deteriorating. Trying to force food down when you don't fancy it is counterproductive and doesn't really work. They'll often look at you very gratefully when they can see that, you know, the daughter who's been trying to cook for you and trying to kind of force you to eat something. Come on, Dad, just have a little bit more for me. You're losing weight. You need to eat. You know, you need to have something. All that pressure that builds up around meal times, it's counterproductive. It's not going to change the outcome. So just trying to undo some of that can be helpful. Again, predictive prescribing, you don't want to kind of wait till somebody is being sick before you then prescribe something. So planning ahead, what what likely to be the cause of this, and then thinking about the route as well. You know, so no antiemetics work if they end up back in the bucket, so you need to make sure that you've got the right route. Thinking about the side effects of both antiemetics as well, and then if they're not working, sort of reconsider what you think is causing it. Is it being absorbed properly? Do we need to add in something else? And just remember, if you're using two drugs with opposing actions, then it probably tells us something. So whenever I see a drug chart where they've got metoclopramide and cyclizine written up, that tells me that somebody's prescribed that without really understanding what those drugs are and what they do. Because metoclopramide is prochromatic, helps us with emptying. Cyclizine has anticholinergic side effects and therefore delays gastric emptying, slows everything down. So the cyclizine is stopping the metoclopramide from working. So what's the point? So kind of when you see that on the drug chart, the same with metoclopramide and hyoscine, you know, they're doing opposing things. So it just kind of tells you that somebody's not really thought it through or doesn't really understand how they work. And then secretions. So this is usually saliva retained in the upper airway. We all swallow about every 10 seconds or so and don't think about it. Where you're not able to because of your level of consciousness, and that saliva will pool at the back of your throat. Breathing through that tends to make the breathing sounds rattly and noisy. Might be made worse by chest secretion. So that might be either because of uncontrolled infection or because of heart failure and fluid overload, that sort of thing. It's usually more distressing to the families and to us listening to it than it is to the patient themselves, because if they were conscious enough to be bothered by the noise, they'd be conscious enough to swallow and manage it themselves. So often when people are dying, this noisy, rattly breathing is something that is just about reassurance to the family more than it is about trying to manage it. It's often seen when patients are unconscious and close to death. And they may also have either rapid shallow breathing or change states respiration or other things which kind of make the breathing seem more noisy or frightening. So good explanation is always first port of call. Trying to explain what's happening and why, and that we don't need to worry about it too much. Positional changes can be more helpful, so the nurses might raise the back of the bed up or even put somebody head down, might put them on their side if they're not, if that's not working. And then we can use antimuscarinic drugs, so using the side effects of anticholinergics to try and have that dry mouth side effect, reduce the amount of saliva they're producing. So hyoscine butylbromide, which is also called Buscopan, is the one that we tend to favour here. Glycopyrronium is an alternative and might work if Buscopan's not working. They usually only work about half the time. So the drugs aren't really the most important thing. It's really about that explanation and making sure that the patient is comfortable and settled. And if they're not, it might be that what they need is a bit more midazolam rather than, you know, ever increasing doses of an anticholinergic that's not working. And I've put oropharyngeal suction in brackets there at the bottom just to remind me to tell you that that's probably not the answer. And we often hear that, oh, well, we need to do some suction. Well, if it's at the back of the throat and you're sticking a tube down to the back of the throat and you make somebody vomit, then suddenly you've got an airway full of vomit, and that's going to make it an awful lot noisier and more difficult to manage. Light suction in the mouth, where people are dribbling and have got kind of a lot of oral secretions, might have some role, but it should really just be at the front where you can see it. It's not putting fingers down the back of the throat or around a trachea. You can do a bit of suction around a trachea, but going to the back of the throat is not helpful. Okay, any questions from a symptom point of view? Okay, so I shall come on. I'll check if anybody's still there. Oh yeah, I've still got some people there. That's good. Maybe not quite as many as we started with. Okay, so I was then asked to talk to you about communication and end-of-life care. So I'm going to start this one. This one's relatively short, and then I've got some cases that sort of relate to it, so I can go through those, and we'll go as far as we want to before you all decide that you've had enough and want to go home. So do tell me when you've had enough. I'll go away. Right. If I put that up, hopefully everybody watching is still able to follow that. So yeah, I'm going to talk about difficult conversations, maybe some ethical dilemmas, things to think about. So as I said, I'm not going to start with the ABC of communication skills. You can look that up for yourselves. I'm sure you've kind of been taught that multiple times at medical school and then throughout foundation years and so on. So you probably don't need me to go over all of that again. I think as you get further on, it becomes less of a checklist of what are the 11 steps, what do I need to remember, and it becomes more intuitive and more creative in terms of having a conversation and how can I relate to this patient. So I'll mention sort of some bits along the way. Hopefully that might be helpful. So I'm looking at difficult conversations. I'll talk a little bit about withdrawing and withholding treatment. I mentioned palliative sedation again, artificial nutrition, hydration, and then a bit about DNA CPR. Okay. So if we're having a conversation with somebody, we need to think about beforehand, what are we aiming to cover? What do we want to get out of this conversation? So if we go in with a bit of an agenda, but be prepared to then put that agenda to one side, because actually it's what the patient wants to talk about is what's most important. But it's usually good to have a bit of a battle plan when you go in to think about what are we trying to achieve here? What do I want to get out of this? So if we're talking about somebody's condition, what do they understand about their condition, assuming that this is a palliative patient we're talking about? What's been said already? What do they understand about the trajectory? What's likely to happen from here? Has anybody talked to you about prognosis, how long this might go on for? Has anybody given you any idea of time frames? Those are the sorts of phrases I might use. And if they say, well, no, they haven't, okay, is that the sort of thing you'd want to know about? Do you want me to talk about that? Sometimes people want to know what we think, other times people prefer just to take each day as it comes. So those, you build up your own phrases. You've got to use something that sounds right to you. So you can't just sort of copy what somebody else says, but those are the sorts of things I might use as a way of opening that conversation and helping people in a fairly non-threatening way to think, do you want to talk about that sort of thing, or would you like to just take it as it comes and we'll just leave it? Might also want to know about what might go wrong. So what are the complications that might happen with this condition? What are the treatment options and what might be available? I want to think about the benefit of what we've got them on. So people turned up in hospital. We've started them on some IV antibiotics, but what are the chances of that making a difference? If they've got advanced disease, is it going to make a difference? Is it going to help things? Or are what we're offering to prolong their dying process for another few days, but actually the outcome will be the same? In which case, is that really something that is going to be of benefit to people? Is that what they want? Thinking about nutrition, hydration, we might want to think, if we're planning ahead, do people want to be here in hospital? Would they want to get out of hospital? When they do go home or to a hospital or anywhere else, would they want to come back? Or is there nothing else that the hospital's got to offer? And the thing that they want more than anything is to avoid being in hospital, in which case we need to make sure that we've documented that properly. And that's where the respect form comes in, to make sure that they've got all of that sort of properly documented. Obviously, there's conversations around CPR. We'll come on to that in a bit. So in difficult conversations, we want to make sure we know what the patient's priorities are. So what do they want from you? And it might not be whatever you're offering them. So they're here in hospital, you're giving them lots of acute treatments. Just check that that's what they actually want, because often people have ended up here almost by default. Somebody else called the ambulance. They didn't really want to get in it, but they felt sort of pushed into doing so. They hate being here. They know what's happening. They don't want to be here. They just want to be at home and just want to get out of hospital. Where do they want to be looked after? Where do they want to be if and when they deteriorate, or where do they want to be for end of life care? So it might be, you say, you know, where do you want to be looked after? Oh, I'd rather be at home. Okay. I can ask a slightly more difficult question. Have you thought about where you'd want to be when the time comes? Have you thought where you want to be at the end? Where would you want to be cared for when dying? And it's okay to use the word death or dying and die. I think sometimes people avoid that and speak in euphemisms and talk around the subject and hope that people read between the lines. Some of us do that very well, others not so much, and particularly people where perhaps English isn't their first language, or with perhaps lower sort of educational levels and things, people might struggle with reading between the lines. And often people say, oh yeah, I had a conversation with them, and go and talk to the patient. They haven't got a clue what you just said because they missed all of that. So we've got to be careful, and sometimes we do have to use the words and spell it out. Offer to answer any questions they have. And questions that you'll often get are things like, how long have I got? Or what would it be like? I don't know, has anybody been asked that? What would it be like? Yeah. So again, having a way of answering that question is often quite helpful. So I'll talk through that. So how long have I got? Well, starting point is up to 1/3 of patients on your ward that you've just come down from, are in their last year of life. So we would count that as end-of-life care. That's what the national documents talk about when we talk about end of life. We're talking about the last year of life. So that's 1/3 of your ward. We tend to overestimate prognosis. So if I ask you how many patients are dying on your ward, you'd probably say 1 or 2, and that would be the lady in the side room who's on the syringe driver, but maybe not thinking about the patients who've been bouncing in and out of hospital increasingly frequently and those sorts of things. We tend to overestimate prognosis. We tend to be a bit on the generous side. MDTs are the best places to try and do that, so getting a view from different people who are seeing different aspects. And that tends to be better than prognostic indicator systems. So there's various studies out there looking at indicator guidance, tick boxes. If you tick all of these and you get a score of over 27 out of 30, then your prognosis is going to be this, that, or the other. All of those things are pretty poor, really. They're not very accurate, and they're not as good as just an overall MDT impression. Within the MDT, who's best, do you think? Do you think it's you guys?
The nurses, maybe?
Resident doctors, do you think you're the best?
Nurses.
Okay, nurses. Right, nearly, go a step further.
Physios or clinics?
No.
Families?
Families are pretty good, although often kind of difficult to get them to, to put a finger on it. Yeah, so it's actually the healthcare support workers or healthcare assistants are the best at estimating prognosis. And the reason is they're the ones who are actually closest to the patient, spend longest with them. So we stand at the bottom of the bed for 5 minutes talking to each other and looking down on somebody and think that we've kind of assessed, because we've looked at scans and blood tests, so we're clever and we've got all that information. Actually, that doesn't tell you very much. Whether it's 5 centimetres or 6 centimetres on the scan isn't really going to give you the answer you're looking for. The healthcare support workers are the ones who are feeding the patient and seeing how long it's taking them to eat a few mouthfuls. And they took them to walked with them to the toilet last week, and now they can barely move and help to turn in bed when they're having sort of care in bed. And unless we've asked them, we don't kind of know that sort of stuff. We don't really think about it. And don't tend to know the healthcare support workers as well as we do the nurses. We tend to speak to the more senior nurses and know the ones who are kind of at that more senior level, who are less likely to be doing those sorts of things that give us an idea. So yeah, just bear that in mind, that healthcare support workers are your friends when it comes to this sort of thing. When we're talking to somebody about prognosis, I would never use a number. So if you're using a number, you're wrong, because you don't know what that number is going to be. And you will either be underestimating their prognosis or overestimating it. And if you overestimate it, then the family will be cross because you said they'd have 2 weeks and they've died in 3 days. If you overestimate it, then they'll be cross because you said I was dying and I'm not, I'm still here. And people really struggle with kind of that, because when they're given a number, well, I was given 6 months and here I am 9 months later. It's like, yeah, but nobody really knew it was 6 months. What they meant was it was likely to be a number of months. 6 months might be a median, so you can see where the advantage of doing that if you're offering chemotherapy and you're trying to say, well, I think your prognosis is about 6 months, but with chemotherapy it might be out to something like 9 months. So that gives you something to work with. But what that's talking about is a median. I'm not going to tell you whether you're the person who dies in a fortnight because you get neutropenic sepsis after the first cycle, or whether you're the person who actually makes it out to 3 years and does really well. So that's the problem with putting numbers on things, that's not what people are asking. They're not asking what's the median survival. They're asking how long will I live for? And the answer to that is we don't know. But I think it is really difficult to say to somebody, you've asked me a really difficult question there, and the answer to that is I don't know. So let's move on. I think you need to give them something. And so what we tend to do is give an estimate in terms of periods of time. So we're talking about in the last few days, or I think it's likely to be sort of weeks rather than days, or weeks to a short number of months, or I think it's months rather than years, to those sorts of phrases. And often we might be right with that. So if we say, I think we're probably looking at weeks rather than months, they might die in a fortnight, and that's fine. Or they might die in sort of 12 weeks, but that's still, a number of weeks, and that's still kind of correct and in the right ballpark. And we tend to be reasonably good at picking which of those people are likely to be in. And it's always worth saying, but that is subject to change. We'll see how things go. It might be things stabilise and it'll look like you're at the upper end of that range. It might be if you have another complication, or if another infection comes along or whatever, then it might look like it's going to be sort of perhaps a bit shorter than that. So that is the way I would sort of tend to talk about that. What will it be like? Well, actually, as I've said, the symptoms at the end of life are quite similar, regardless of what the actual diagnosis is. And we can usually control those reasonably well with those 4 anticipatory drugs. So an opiate, whichever one you choose, and then midazolam, levo, hyoscine. So what we tend to say to patients is, well, what will happen is as you become less well, people tend to become less mobile, they spend longer in bed, less able to kind of get up and about and look after themselves, needing more help with things. Appetite tends to diminish and people tend to eat less, just be able to manage a few mouthfuls. You might notice that these sorts of things are starting to happen already, and they say, oh, well, I'm largely in bed now, I can't get up and about, not really eating very much. So I can see those things are happening. What tends to happen then is that people gradually become more drowsy, so sleeping for longer periods. So, having naps during the day, and then getting to a stage where they're sleeping most of the time, might just wake up when somebody comes in and says hello, and then sort of, when they're left alone, drift off back to sleep again. And then we get to a period where people aren't really waking up at all, and that's when we know we're in the last few days and time's really very short. And then what tends to happen is that people slip away quietly from there. It doesn't tend to be dramatic. It doesn't tend to be anything sort of more than that. We know that things have come in. It's not usually sudden or unexpected. We can normally see which way things are going. We know we've got to the last few days. Family are all around and aware and, are visiting when they want to. And then people gradually slip away. We wouldn't expect any symptoms that people haven't had up to now to become a problem. Okay, so if you've had pain, patients might be talking to you about their pain, you might say, well, we'll carry on your painkillers, we'll keep giving those, we've got different ways of giving them to make sure we can carry on giving you painkillers, so we'll carry on managing those. We wouldn't expect you talked about dying in sort of, in distress because you're breathing. Well, you haven't had any reasons for breathlessness up to now. We wouldn't expect that to become a problem. So if you haven't had these things up to now, we wouldn't expect them to be a problem. But we'll make sure that medications are written up in case you need them, and then we'll be able to control those if they do come along. And usually people at the end of that say, do you know what, that's really reassuring. I feel much better for having asked you. I'm glad that you've said that. So sometimes it is worth prompting people to say, have people spoken to you about what it would be like? I can see, particularly when people are anxious and worried and look frightened, you can sort of say, do you want to know what it's like at the end? Because what people will have is either they'll have a memory from, childhood when, great uncle, whatever his name is, died, and that was remembered as this story of this horrendous thing that happened, which may or may not be kind of true, but it's how people remember it. Or their experience of death will be what happens on TV and in films. And by definition, it's dramatic because it's in a drama. So it's not real life. That's not what people do. If you've filmed people actually dying in a film, a really boring film, because it's just people slowly deteriorate and gradually lose ground and then gradually slip away. So it isn't sort of dramatic or exciting in any way. So you can normally reassure people quite well and people feel a lot better than that. So if we're thinking about withdrawing and withholding treatment, so there is no legal or ethical distinction between those two things. They feel a bit different. So you may decide not to start something, but once somebody is already on something, it then feels more difficult to stop it. So, for example, starting kind of artificial feeding. If somebody's deteriorating, you can see the time's quite short, you're not going to stick an NG tube down and start feeding them. But if they've already got one in, it's quite hard to stop their feeds and to take that tube out again. That feels like a more difficult sort of conversation to have. And so often it doesn't happen when it perhaps should do. What we need to be careful of is that we're not worried about stopping things and therefore don't start them in the first place when they might have been beneficial. Knowing that you're allowed to stop things gives you the permission to start it and give it a try. So we need to sort of think in those terms, really. But if we're trialing treatment, then it may be that what we need is a very clear stop review date. Okay, so if somebody comes into A&E or admissions unit, they've got cancer, but they've come in with a chest infection, and we don't know whether they're going to respond to treatment or not, but they would want to be treated, and they're respectful and said they would go in for an infection. So it's reasonable to start treatment, but be very clear with the patient and with their families and say, well, we'll try it, but we'll try it for 48 hours and see. I'm not sure whether it's going to work or not. If over that 48 hours we've tried antibiotics and things are improving and they've picked up, then we'll carry them on and complete the course. If over that time actually they've lost ground further and they're deteriorating, then they're not going to be working, and so we'll stop at that point. But we'll give them a good try. We'll see if they make a difference. But if they don't, then we'll stop and we'll change to sort of focusing more on keeping people comfortable. Okay, so that's the kind of conversation you might want to have. Palliative sedation, I've probably touched on this a little bit already with the symptom management bit. It's a term that's used. It's not an ideal term, but what we're aiming for is symptom relief. So we're not looking to sort of hasten death, but we can use sedation if people have uncontrolled symptoms, and that's pain or breathlessness, as well as terminal agitation. And as I said, we have this stepwise approach. We're trying to find the lowest effective dose. We don't usually need to go as far as continuous deep sedation, but there are times when we might need to. But what's really important is to involve the patient or their family in that process, in that decision making, and make sure they're on board with it. And as I said, people will often say, look, I don't mind being more sleepy as long as I'm comfortable. So if you can get that said, then you've got permission then to be a bit more generous and to go, if you're sort of toying between two different doses, do I give 5 or 10? It sort of prompts you to go for the more higher dose. My view of these things, one way of thinking about it is if you think about what medication you want to give to somebody and they are nearing end of life and they're struggling with their symptoms, what dose should you go for? Do you go slightly higher than you think or slightly lower than you think? And a good rule of thumb is to be cautious, to err on the side of caution. But it's important to think if somebody's dying and they're symptomatic, what is the cautious side of the equation? Is it to give them slightly less than you think and risk them being more agitated and distressed or more difficult symptoms? Or is it to err on the side of giving slightly more than you think and have them more drowsy and less responsive? Well, if they've told you that they don't want to be here anymore, they're dying, they just want to be kept comfortable, and you can see that actually they're becoming more drowsy anyway, and they're not really rousable, they're not really waking up or not having a conversation with you, then giving them a dose of medication that's slightly lower than you think isn't going to change that. It's not going to wake them up. Giving them slightly more might make them a bit more sedated, but it's just going to make them more comfortable. You're not what you're losing in terms of that communication or being able to eat and drink and those sorts of things, you've probably lost anyway by that stage. So it's worth thinking about. I would err on the side of caution by giving slightly more than you think, because the most important thing not to miss is keeping them comfortable rather than them surviving a bit longer or being able to be a bit more alert and awake if they're already losing those things. So just a different way of thinking about it is sometimes helpful. Okay, if we think about nutrition, so as patients deteriorate, they have a reduced oral intake. That is a natural part of the deterioration of dying process. And there's lots of other reasons why they might have that as well. So that might be to do with obstruction of the GI tract at some level, the anorexia cachexia syndrome that people get with advanced disease, generalized weakness, obstructions are mentioned, loss of desire to eat, loss of appetite, and then as they lose their conscious level, as they become sort of more terminal as well. So lots of reasons why people stop eating. There was a Cochrane review that was done a few years ago looking at studies around enteral and parenteral medically assisted nutrition. So putting tubes into people to feed them. And does that work? Does that make any difference? And so they looked at, does it for a long length of life? So does it help people survive longer? And does it improve their quality of life? So does it reduce their symptoms? Does it give them better quality of life? This is for patients with a range of different conditions, but all sort of heading towards that kind of end of life in the last few weeks or months. And the answer is there wasn't really much evidence either way. So in terms of good quality evidence, randomized controlled trials or prescriptive control studies, there wasn't really much to go on. There was non-controlled trials where there's a whole mixed bag of evidence. But there's lots of side effects as well. So for home parenteral nutrition, so in through a vein, that has more serious and consequential side effects. But also, it became quite a burden for some people to have to kind of, have this stuff being sort of given and done. So the conclusions of the Cochrane review were that there isn't really enough studies to make any good recommendations for practice. So you could argue that that means there's no evidence for doing it. There's not an awful lot of evidence for not doing it either. So you could kind of weigh it up. It does say that there may be some benefit for patients with a good performance status and a prognosis of months to years. So if you're talking about somebody with motor neurone disease in their early stage of disease where they've lost their swallow or struggling with their swallow, but they're still up and about, they're still quite alert and awake, there may be some benefit in a PEG, or at least offering that if people want it. If people are deteriorating and getting to the stage where they're largely bedbound, they're not really able to do very much for themselves, they can't now swallow safely, sticking tubes in does not alter the outcome here at all, and it may cause more harm than good. What's the main harm of putting an NG tube into somebody in hospital, do you know? If you're talking about this circumstance in end-of-life care? Yeah, so there are side effects, you can put them in the wrong place and feed them. I think there's something more kind of likely to be a problem than that. Takes away their choices. So somebody might want to be at home. They might want to go to the hospice or to the community hospital, Butterfly Hospital around the corner, Butterfly Hospice rather. If you've got an NG tube in, then you're condemned to staying in hospital, really. There are one or two nursing homes that might be able to manage that, but not many. And even then, if it stops working, do you come back in, have it replaced? All those sorts of consequences need thinking about. So the GMC have said that providing nutrition, hydration, can provide symptom relief and prolonged quality of life, but may also present problems. So they're saying the current benefit is not clear-cut. So there isn't really any clear evidence one way or the other. Nutrition hydration by tube or drip is a medical treatment, and like any other medical treatment, we need to decide and weigh up the benefits, the costs and benefits, risks and benefits. So nobody can insist on a tube to feed them. You've got to make a medical decision as to whether or not you think that is indicated, whether the risks whether the benefits outweigh the risks. They said it's really important to consider the views of patients and those close to them, and explain the benefits, burdens, and risks. Offering food or drink by mouth is part of basic care, so that should always be offered, as long as there isn't a serious risk of aspiration. So food and drink can be refused at the time it's offered, but you can't have an advance decision not to be offered food orally. Okay, so just they're drawing a distinction between sticking food and drinking through a tube and feeding somebody in the usual way, offering food and drink. So they are different. So medical treatments are something you need to weigh up and decide on the benefits. There are alternatives, so mouth care, comfort feeding, allowing people to have a little bit of what they fancy. They know the risks and they can make an informed decision. If you're going to do that, you need to decide what you're going to do when they aspirate. So if they get a chest infection, do you rush them back into the hospital? Well, not really, because there isn't a way out of that, because they're going to carry on wanting to eat. So it's thinking about, if that does happen, then we'd manage you symptomatically. Oral nutritional supplements, so these little sip feeds, they might not be able to manage a meal, but they can manage to drink, so they can have little sip feeds and feel they're not going to change anything. They're not going to make people live longer, but if they like them and they feel that, well, I'm getting some nutritional benefit, I'm getting some vitamins and minerals, that's got to be good for you, then that's fine, and that might be helpful. But don't try and sell it as this is an answer. It's not going to change the outcome. And then again, this MDT approach and looking for extra help with that when necessary. Artificial hydration. So this is something that we see quite often in hospital because people come in, they get a drip stuck up, and because they've got a drip going, nobody ever wants to stop it if they're not drinking. So we need to think about reversible conditions. Are they dehydrated? Have we got hypercalcemia or any other sort of treatable thing that might be necessary? Sometimes it might be appropriate to give a trial of fluids to see whether it makes any difference. Does it then wake somebody up and they can go back to drinking for themselves? If it doesn't and they can't, then it's probably not going to add anything. People worry about being thirsty, but that reduced fluid intake that people get isn't really the cause of thirst. Those two things aren't really related. Thirstiness is more about the dry mouth, and that's probably more to do with the side effects of the medications. All the anticipatory drugs can cause dry mouth as a side effect. Again, when they look at the evidence, there's another Cochrane review around all of this. There isn't really any clear benefit or harm from fluid therapy, but it's often felt to be an unnecessary medical intervention. If they do have fluid collection, so either peripheral edema or pulmonary edema, then that might be a problem. And it can worsen things like ascites or effusions. If they get respiratory secretions, we're putting hyoscine up in the driver to try and dry them up. And there's no point having fluids going in the other side. We're doing, again, two things with contrasting actions, and therefore they're counteracting each other. It's amazing how often you see that. They've got IV fluids on one side and hyoscine on the other. That is not going to work. And again, with bowel obstruction, often we're giving hyoscine, they're vomiting. We're trying to reduce that, and then we're putting fluids up because they're not drinking, and not able to take fluids in. Surgical wards have often got IV fluids. The IV fluids drip and suck, NG tube, and then because they're not going to take them to theatre because they're not well enough, they then get really stuck. They wanted to put hyoscine up, but they won't take the fluids down. And they're vomiting, or the NG tube is having a huge amount of stuff coming out of it. And that's because they're pouring it in. And the more they pour in, the more comes out. I feel like putting a bit of blue dye at the top sometimes, just to then show that 5 minutes later the NG tube bag has gone blue, just so they can see that actually you're driving that, you're causing that to happen. Okay, and then finally, I was just going to talk about DNA CPR. So the chances of surviving cardiorespiratory arrest varies considerably, as I'm sure you're aware. Depends on many factors: age, functional status, comorbidities, cause and circumstances of the arrest, what's caused it. In hospitals, average survival might be around 15%. Where are most of those patients?
ITU.
Yeah, ITU or CCU. Okay, so it's people who've had a cardiac arrhythmia as part of an MI, and you might see it as an arrhythmia as opposed to a cardiac arrest. It's an arrhythmia that is non-compatible with a cardiac output, but if you shock it back into a normal rhythm, everything else carries on. So you might see it as management of an arrhythmia as opposed to a cardiac arrest if somebody's had a cardiorespiratory arrest for other reasons. So it feels a bit different there. So yeah, that's where people survive. So, your little old lady on the general care and elderly ward, the chances of them surviving are much lower. Okay. Out of hospital, the survival rate is usually much lower, and that's often to do with the amount of time it takes for decent CPR or electricity to be applied. Are we getting better or worse at managing CPR? Are our survival rates going up or down?
I don't know, but I'm going to guess up.
Yeah, you'd hope so, wouldn't you? Yeah, they are going up. Why?
Because we're better at putting DNA CPRs in people who aren't satisfied.
So we are not getting better at keeping people alive. We're not getting better at doing CPR, or not significantly. We are getting better at not doing CPR. So we're getting better at appropriately stopping CPR, or not starting CPR and making sure that people have DNA CPR orders in place. So we're getting much better at not doing that. When I was at your stage, they'd often sort of not think about these things at all, and then they go, "Oh right, let me have a look at that." So we'll do one cycle just for practice, and then we'll stop. And that sort of thing was quite common. These days, I think people would have a slightly different attitude to that and think, well, actually, we shouldn't be doing this in the first place. And you might investigate why we're doing CPR for somebody where it's clear that that wasn't never going to be appropriate. There are risks with CPR. So rib and sternal fractures, my first ever chest compression, I broke a rib. That stays with you. Then go running along and say, be careful. Oh, well, crack. Obviously, rupture of underlying organs and things. Usually, people who've had proper cardiorespiratory arrest will need a period of time in ITU, often on a ventilator. So if they wouldn't want to be on a ventilator, then they're not really going to be a candidate for CPR. And sometimes people say, I wouldn't want that, but I would want CPR. And so, no, that's not going to work. So we've got to be really clear what we're offering there. They will need a period of treatment in an intensive care unit of some sort. And there is a significant risk of hypoxic brain injury and resulting disability as a result. The worst outcome I saw from CPR was somebody who should never have been given CPR. They had advanced cancer. It wasn't appropriate. The CPR was performed. They managed to get them back. And then they had significant hypoxic brain injury. I think they'd worked on them for quite some time before they got them back. And it's a real shame that they did, because they then had hypoxic brain injury. They never came round, they never woke up, but they did fit for 4 days straight. And ideally, they needed to go to ITU and be sedated, but obviously they weren't a candidate for ITU, so they had sedation on the ward. And I didn't really get the palliative care team involved until kind of 3 days in, and we managed to settle the fits down and they passed away sort of peacefully in the end. But basically, the family sat around the bed watching them fit for 4 days. So the worst outcome from inappropriate CPR is not that the patient dies, they survive, and the outcome is terrible. They died anyway, so they didn't get any benefit from it at all. So we've got to be quite careful about that. So yeah, do make sure that we're thinking about that. So there are a couple of court cases that are worth mentioning. So Janet Tracy was a woman who, I think on behalf of the family, on her behalf, took it to court when a DNA CPR order was put in place without her knowledge. And so the court judgment was that we have a legal duty to inform patients if they have capacity, which she did have at the time, that we're putting a DNA CPR order in place. The presumption is in favour of patient involvement. We've got to have a very good reason to decide not to speak to the patient. If we do, we've got to be able to justify that. However, they did confirm, as had always been the case, that we are not required to provide CPR if we think it's not going to work. So it's a medical decision. We are not under any obligation to provide any medical treatment that we don't think is appropriate or don't think would be able to work. People do have a right to ask for a second opinion. They don't have a right to insist on a treatment that you don't think is appropriate. So it is okay to say no, okay? But you do have to involve them in it. If you don't tell somebody, you're denying them their opportunity to ask for a second opinion because they didn't know about it, okay? And then there's a a chap called Winspear, Carl, I think, Winspear, who came to court a year later. This was a lad with profound mental and physical health, or mental and physical disabilities. He had no capacity, never had capacity to decide anything. He had epilepsy and all sorts of different medical conditions. And what happened here was that, again, we put a DNA CPR order in place, to be fair, in the middle of the night. And they decided not to ring my mum in the middle of the night, but contact and discuss it the next morning, which they did. Mum objected. It was revoked, which it shouldn't have been. The patient then sort of died later that day, but they had managed to kind of put it back in place by then. But the court judgment was you need to follow a proper best interest process here, and you didn't, because you made a decision without involving the family. So what they should have done is ring the mum at 3 in the morning. Now, not unreasonable to think, I don't want to ring them at 3 in the morning, I could wait till the morning. It's like, well, could the decision wait till the morning? And there's a decision has to be made at 3 a.m. because he actually died within 24 hours or so. So, probably it was appropriate on the senior review to make that decision at 3 in the morning. So they should have run more. So, just be aware that making a best interest decision is not what we think is for the best. It's what would their patient have wanted, what would be appropriate, involving their family and in discussions. Okay, so there is something about dealing with uncertainty. There's often a lack of evidence in palliative care. There's no right or wrong answers. The studies that we have often show that there's no evidence one way or the other, or it's difficult to kind of involve people in decent quality research. But we need to have a flexible approach. We need to think about being willing to change course. But the general principles are, sort of first, do no harm. So if what we're offering is that we can keep people alive, but not really get better from their underlying condition, but instead of dying tomorrow, they'll die in 2 or 3 days' time, because we've treated their infection and given them lots of fluids and sort of kept them going a bit longer, but we've prolonged their dying process, then have we offered anything of any benefit? And is that a benefit to the patient? Well, you can ask them. But if they don't really think it's likely to be of any benefit, but has the potential to cause harm, then we shouldn't really be doing it. So do no harm is important. If we're not doing any benefit, then we might be doing harm. Think about the patient's priorities. We only know what they are if we talk to them and try and ask them properly. Sometimes what we're aiming for is the best quality of life for the time they have left, without necessarily looking at what can we do to extend that quantity of life, if that will only make things worse. But obviously communication in all of that is really important. Any questions about any of that? I appreciate that.
So I work in respiratory, but this kind of is more generally applicable. So obviously there's lots of patients on the ward who've got COPD.
Yeah.
And that is a progressive condition, and eventually they will probably die from that, if not something else first.
Yeah.
So how do you know at what point in their illness to start talking to them about end of life?
Okay.
And kind of symptom management and that kind of thing.
So that was a question about patients with COPD. How do we know when they're at the reaching that kind of stage of life where we start talking about their wishes and the life care? The answer to that is that there are various things. There are talks that I've done before on recognition and how we recognise patients. There's a tool called the SPICT tool. There's also another one called Prognostic Indicator Guidance, which is part of the Gold Standards framework. So there's various things out there that give you clues as to kind of what might be general indicators of decline. So people, as I said, needing more help, less time up and about, less able to look after themselves, help with activities of daily living. And then there are more specific things for respiratory disease, and that might be to do with the number of infections that they're having, whether they're on home oxygen, whether they are, how often they're needing to be admitted to the hospital. What we tend to see is people are admitted more frequently, they spend longer in hospital, they go home, but they never really get back to their baseline. They're spending short periods of time at home and then back in again. And that frequency of readmission sort of tells you that that things are deteriorating, time is getting quite short. So when you start to see any of those markers, that this is the 3rd admission since Christmas, then that's when you should be talking to them. When the patient themselves starts to kind of express their dismay at how things are going, that they don't feel that they're getting better, that they're struggling with these symptoms, and sort of psychological things start to come in, then you can start to think, actually, should we have a different focus here if it's appropriate? When they're finding it really hard work, when they're starting to complain about how many times you're sticking needles in them to get blood gases, I would hate to spend kind of the last few weeks of my life having people taking blood gases from me every 3 times in an evening. It's a horrible way to sort of live, really. So just thinking about, if this was your mum, would you want what you're offering them, or would you want to start thinking about something different? So those are the sorts of things that you might want to focus on. Okay. Any other questions? Okay. What time do you guys normally stay till? Because I've got some cases that I'm happy to go through if you wish to, but I don't want to keep you here. I'll let other people on screen be involved in that as well. So I'm quite happy to, go through a few cases and sort of carry on until you've had enough. Do you normally finish by 4, or are you normally here till sort of 6 o'clock? Or?
I think we normally finish kind of around 4. Yeah.
4-ish. Okay, fine. So I might just put the first couple of cases on, give you something to think about, and then we'll sort of stop when you've had enough. Those of you on screen, please do join in, but I'm aware that you can also just flip off when you've had enough, and I'll never know. Okay, so these are some of the kind of things that I've come across. These are all real cases and sort of real decisions that we've had to think about. And a whole list of different things that we've had discussions about, but I'll come to them. So first case is a 75-year-old woman. She's had bilateral middle cerebral artery infarcts. She's been in hospital for 7 weeks. So bilateral strokes. The problem with bilateral strokes is that you've got less on the other side to recover, and therefore they tend to have poorer recovery. GCS4 after 7 weeks, not usually a good sign. She would open her eyes when you sort of shouted to her, but didn't really doing anything else, and no sign of improvement. Been NG fed since admission. Interestingly, when I was a sort of junior doctor doing my stroke ward thing, you would normally not put tube in for the first 2 weeks and see which way things were going, see whether people were going to recover or not. You didn't want to put tube in and ask to take it out if you found that they were not recovering. Now, as you might expect, people do less well if you don't give them nutrition, so that we're reducing their chance of recovery. So that has changed for the better. We now put tube in and feed early, but it does mean that we're left with these difficult decisions sometimes about whether you carry on or whether you stop. And stopping something that you've started, as I mentioned, withdrawal is sometimes more difficult than withholding in the first place, or at least feels more difficult. Anyway, tube in. Recurrent chest infection, so she had 3 courses of antibiotics already since she's been in. Okay, so that is important in itself. And then referred to the palliative care team to help plan discharge. So what are the sorts of things that we need to think about here? What are the issues that we need to bear in mind?
She's got an NG tube and you said that we can't discharge with an NG tube.
Yeah, so where can you go with an NG tube? Anywhere?
Can you just ask us?
You can. Our first question would be, why should an NG tube in? So we'd want you to have thought about that before we'd accept her. We can do it. We will if we need to. But I think our answer would be no in this case, because she doesn't need hospice care. She has no symptoms, no awareness, so we're not really adding very much. She was here in Boston, and the hospice is in Lincoln, so it's a long way to travel. We really need to make a decision as to what we're doing rather than that. There are 1 or 2 care homes that will take people with NG tubes in, but again, you'd ask the question, why are we doing that? So what are the alternatives?
Rehab? Was it 1?
Okay, it's been in 7 weeks. Oh, were you saying go to the rehab ward? Yeah, they wouldn't feel that there was any rehab plans. Sorry?
Very low CCS for it.
Yeah, 7 weeks on, she's GCS4, there's no recovery likely here, so rehab wouldn't have anything to offer. Okay.
So it sounds like she's quite unlikely to recover in any meaningful way. So then I guess, are we okay with taking the NG tube out?
Okay. Are you okay with that?
I think so, yes, because I think all we're really doing is prolonging her life and probably prolonging suffering in a way that isn't kind.
Okay, so we're saying that we could take the NG tube out because we're just prolonging things at the moment and it's of no benefit. Is it keeping her alive?
Probably not.
Okay.
Because I think.
Would she have lived 7 weeks without it?
No.
Okay, so it probably is actually keeping her alive at the moment, isn't it? Or at least it has done up to now. Okay. Has it the potential to do harm?
So yes.
Yeah, she's had 3 chest infections so far, hasn't she? Where's she getting them from?
Aspiration.
Yeah, so she's lying flat. We're filling her stomach with liquid feed. She's GCS4, so she can't protect her airway. We all regurgitate all the time and protect our airway and stop that going down the wrong way. If she's unable to do that, is lying flat with the stomach full of liquid feed, then she's at high risk of aspiration. And she's proven that by aspirating 3 times and having chest infections. So she's at high risk of that, and we might be making that worse. So we can't necessarily promise that carrying on the NG feed is keeping her alive longer. Actually, there is a possibility that she might die earlier than if we hadn't done. Okay. But, you know, clearly it is keeping her alive. It's doing something, isn't it? Okay. So the questions here around discharge are where is the best place to provide ongoing care, and where would be able to manage her feeding if that was to continue. So there really is something about the feeding, first of all. If she was discharged somewhere, what's going to happen next?
She's going to get a chest infection and they're going to send her back in again potentially.
Yes and no. If she's going to get another chest infection, they're then going to have to decide whether to send her back in again or not. You can help guide that. So we have this sort of helplessness in hospital where we're going, oh no, they've sent them back in again. Why on earth have they done that? They've done that because you haven't told them not to. So we need to be really clear whether or not that's appropriate. And that's a conversation, isn't it? So it's a conversation to have with family. So what's really important here is to then have a proper family meeting and decide where we go next. So a decision was made not for any more IV antibiotics. Fair enough, sounds very clear. A week later, she got a chest infection and started on IV antibiotics. Amazing how often that happens. Okay, when people are in hospital, it's very difficult not to do things because we can, rather than because we should. And that wasn't working, so they switched to second-line IV antibiotics. Okay, remember your consultants change over every week or two, so you get a different person looking after them, or it'll happen out of hours at a weekend and somebody doesn't know them. They'll say, well, they ought to. Nobody reads back in the notes properly. And so we often see this sort of thing. So being in hospital is a dangerous place. You can't stop people doing stuff. Really difficult to stop the junior doctor in the middle of the night starting something, and then they ring their senior for advice. He'll say, oh yeah, I think so, that sounds reasonable, do that. Okay. The consultant said that they were struggling to get the sons to accept that there was no chance of meaningful recovery. I always like a challenge. Whenever I'm told that this family are going to be really difficult, it's amazing how often they're not. So I met with the family, and the 2 sons were fully accepting that she wasn't going to recover. And in fact, they told us they'd been through this before, because Dad had dementia and he had recurrent infections. It wasn't a stroke, but it's the same sort of idea that they couldn't swallow safely because of his level of dementia. He got recurrent infections, and they've been through that kind of under life planning and stuff with him already. So I don't know what conversation the consultant had with the sons. Or whether he was thinking back to sort of, much earlier in her diagnosis. But actually, that conversation with the sons was manageable and perfectly fine. So we discussed whether to carry on with the NG feed. So we've already talked about this a little bit, but what are the pros, first of all? Why should we carry it on?
She'll die without it.
Yeah, so it actually probably is keeping her alive, or at least has done for 7 weeks, and she's not going to live another 7 weeks without it. So it might be keeping her alive. To what end?
Medications, if you can get her medications.
Yeah, okay, so there may be some medications you can give that way. You can give most medications that you might need subcut, which is obviously what we do in palliative care. But yeah, there might be something beneficial in there, including treatments for a stroke. You kind of aspirin and ACE inhibitors and all the kind of other things that people get started on. They've got more chance of getting those sorts of things in if you've got an NG tube or another tube. Okay. Gives her a best chance of recovery as well, doesn't it? If she is going to have any recovery, she's not going to do it without nutrition, so it gives her the best chance. But I think we already know that that's not really the case. So the only other thing, what's the only other thing that might be of benefit here? Do feel free to shout out on screen if you've got any ideas. That's the trouble with teaching people on screen. Nobody ever talks to you from screen. The only other thing is whether it's actually easier for the family to accept. So there is something about families being able to say to themselves, well, we did everything we could, we gave her our best chance, or, you know, really struggling to cope with the idea that we weren't feeding her and she starved to death. She didn't starve to death, she died of a stroke. But, you know, people see it in those terms. So sometimes there may be some benefit from a family point of view in thinking about that. So what are the cons then? What are the downsides of carrying on NG feeding here?
It's not very nice having NG tubing.
Yeah, so it's a bit unpleasant, and sometimes people will, if we're alert enough, will pull them out. What do we do when they pull them out? Yeah, and then if they pull them out again, what do we do?
Foot grinding.
Yeah, tie it in, yeah. And then what do we do to their hands? Yeah, so we stop them from pulling them out. I mean, we might as well handcuff their arms to the side of the bed. You know, I think these things are cruel and unnecessary, really. If somebody keeps pulling it out, they may or may not have capacity, they can still tell you what they want, and they don't want that tubing. You really need to think quite carefully about whether we should be replacing a tube that people are deliberately pulling out. Yeah, anybody can turn over in bed and pull it out by accident, and that's fine. If they then consent coming back in, then fair enough. But people are repeatedly pulling it out on purpose, just ignoring their wishes and saying, well, we're going to keep putting it back in again because we know best. I'll think quite carefully about it. Okay, should be a best interest decision, and that includes what would the patient have wanted, and they're telling you what they want, even if they don't really understand the consequences. So you just need to, I'm not saying you should never do it, I'm saying you need to think quite carefully about it. Okay, for me, it's about medicalising death. So dying with feeding tubes and things in is a medicalised way to die, and not necessarily the best way of doing that. It hugely restricts her discharge options, so she can't go to the hospice, she can't die at home, which she might have wanted. Can't die in a community bed closer to home, so family can visit or friends can visit, or to bring the cat in, or whatever it is like that. And then increasing risk of things like it getting dislodged, risk of aspiration, which may be causing harm here. If we're doing it so that she's not distressed when she's dying, if she's starving to death, she'll be distressed. Well, first of all, we need to be careful about emotive language like starving to death, because that's not really appropriate. And then we've got to think about what's the best way of managing agitation at the end of life. Well, drugs like medication, like midazolam and levodopa, far better than a tube with, nutrition. Okay. So the decision was made to stop the NG feeds, and we all agreed that she would discharge to a community hospital close to home for end of life, and she wasn't going to come back for further antibiotics. I was then asked by the consultant at the desk with loads of people around, is this ethical and does it require a court order? How can you do that? Is it ethical to stop feeding somebody? Does it require a court order?
I don't think it requires a court order.
Okay. Would it be if it was a persistent vegetative state? And in what way is this different than a persistent vegetative state?
I think because with or without the NG feeding is end of life, she's not going to manage this. Whereas I think people in persistent vegetative states, provided you keep feeding them, they should continue to, at least for a short while, be okay.
Yeah, so you're sort of making the assumption there that if we carry on feeding her, she will deteriorate and die. And I don't know whether that's true or not, apart from the recurrent aspirations. So if she didn't have those and she hadn't had any aspirations, then what is she deteriorating from? And so in what way is that different to a persistent vegetative state? The answer is that they clarified the law to say that persistent vegetative state isn't really a thing anymore, partly because it's got the word vegetable in it, which is an awful term. But we now talk about PDOC, don't we? Persistent disorders of consciousness. But actually it doesn't require a court order to stop feeding in those circumstances, and it is a decision that we make all the time. The problem here was the consultant couldn't abide the idea of stopping it. So that was something personal to them and their own beliefs. That was the problem. But actually, it is ethical to stop a medical treatment. I've already said that these things are a medication and they're a medical treatment rather than basic care. Feeding somebody through a tube, I think quite carefully about whether it's appropriate. The other option, of course, is to put a peg in. So if suture is a bit better than this, but still didn't recover her swallow, then you would put a peg tube in or consider a peg tube. If you're not going to do that for her, then you shouldn't be feeding her through an NG, because it's the same concept really. So if she's not well enough for a peg, and you wouldn't think that was appropriate, and if you ask somebody to put a peg in, they would say no, it's not appropriate. So therefore, you should then think quite carefully about whether you stop the NG tube. So sending people out with an NG tube is problematic. What you've got to be careful of is you don't go out with an NG tube and then not have a clear plan for what happens when it blocks, when it gets dislodged, when she gets the next chest infection. What are you going to do in those circumstances? Okay. I'll come on to the second case and then I'll stop at that and let you all go away. So an 83-year-old woman with an ischemic foot, which is necrotic, not fit for surgery due to her existing heart failure, eating and drinking small amounts, been relatively stable over the last 4 weeks. She's been in hospital for quite a while. So what do we need to think about for discharge to a nursing home?
Like wound care in the community.
Yeah, so how are we going to manage that? What sort of care is she going to need?
PVN, community.
Yeah. So looking at nursing care and tissue viability nurses. What else do we need to think about?
Would you want to come back to hospital if she became poorly? Or...
Yeah. The only problem with that sentence is one word. Which word is it that I don't like, that I'm going to react to in that sentence?
Poorly.
Like, would you like to?
No, would she like to? It's fine. Become more poorly. I think that's perfectly sensible language for talking to the patient. Yeah. If she becomes more unwell.
Okay.
Okay. So think about that. Is there an if here or is there an when?
It's a when.
Yeah, she got a necrotic foot. That's going to get septic. She's going to get ill. So think in those terms. It's not if, it's when. I'll say that to patients or families sometimes. You know, when you become more unwell, and it's not if, it is going to be when. It will happen at some point. What are we going to do at that point? Okay. So what are the options when she becomes more unwell?
They could look after her in the nursing home.
Yeah. Or
Readmission.
yeah, bring her back into hospital and give her IV antibiotics. Okay. What are IV antibiotics going to do for her?
Nothing, because we didn't treat the cause.
Yeah.
We were just raging for 3 days and then she would do it again.
Yeah. So in the short term, they'll make her feel better because they'll clear the bloodstream. So she will have bugs floating around in her bloodstream and will feel really unwell as a result. And we can stop that and we'll make her feel a bit better. But the underlying source is a dead foot. The antibiotics aren't going to get into it. We can't sterilize it. Sooner or later, whatever bugs are in there are going to become resistant to whatever antibiotics you're throwing at her. So they're not going to change the outcome. They might make her feel better in the meantime, which isn't a bad thing. But we're bringing her back into hospital to give her IV antibiotics be appropriate in those circumstances. And some of that depends on what she thinks and what she wants. Some of it depends on kind of what their understanding is of what's going to happen. So this is that bit about what do they understand about the trajectory of their illness, what they said about the likely complications, what's going to happen, what you might be able to do and not do in order to make things work. Okay. So this is where we need to think quite carefully about readmission, whether that's appropriate, how we're going to organise that, and what we're going to do. So she started to deteriorate while we're faffing about sorting all that out. She became more unwell. Stopped eating and drinking, became more drowsy. Blood pressure was quite low. So no doubt she was sort of triggering news scores and people worried about all of that. She was on some medications. The consultant, this is on the vascular ward, started IV fluids because she's not drinking. And she started to develop a bit of peripheral edema. So how would you manage all of that? What are you going to do?
See the patient's wishes and discuss with the family the outcome and the thought.
Okay, so patient's wishes, drowsy, difficult to kind of get to understand that anymore. We knew what her wishes were, which were to be discharged from hospital, heading out to a nursing home, wasn't she? So that was the plan. So we knew what her wishes were. Okay, what else?
Stop the IV fluids.
Yeah, so what are IV fluids adding here?
Not a lot. I think the idea is that they'll make her blood pressure a bit higher, but I'm not sure what kind of.
It's making her overloaded as well.
Yeah, she's developing peripheral edema, isn't she? She's got enough fluid on board, it's just all in the wrong places. Pouring more in doesn't mean that it goes in the right place, it just means more of it ends up in the wrong places. Okay, anybody with huge peripheral edema, you've got to think quite carefully about why you're giving them fluids and where that's going and what you're trying to achieve by doing that. Okay, what else?
Start to get them comfortable.
Yeah, so we need to focus on comfort measures, don't we? I think that's entirely appropriate. Yeah.
And if she stops eating and drinking, we need to discuss with the family, like how long this is going to, the prognosis of it.
Yeah, so conversation with the family about prognosis. Yeah, so.
And because morning, like moderate conversation with the family, start what's and probably fast track the situation if she the wish is to not get out of the hospital.
Yeah. So it might still be that we carry on with the plan as it was to discharge her from hospital. Nobody want to stop her medications at all?
What should have been stopped before IV fluids?
Yeah, but they aren't.
So
Okay, stop them.
Yeah. So she's still on a beta blocker. She's still on frusemide, so we're pouring fluid in and then making her pee it all out again. Spironolactone, much the same. So she might not need fluids if we just stop doing kind of stuff that isn't that helpful. They should have been stopped before, but certainly should be stopped now. So yeah, I went in, I said that there's no role for IV fluids here. She's got plenty of fluid on board, it's just all in the wrong places. We need to stop her diuretics and we need to stop the beta blockers. It depends what beta blockers are for, so you've got to be careful with beta blockers. If they're for, fast AF or SVT or something like that, you don't want to kind of put somebody back into arrhythmia. So you might want to just check what they're there for and, they were part of her peripheral vascular disease, I think. I think they were for arrhythmias particularly. Even then, you might want to stop them because of the blood pressure. Discussed with the family, they agreed that we're aiming for comfort care. She can eat and drink as able, but she wasn't really getting very much in, but stop IV fluids and continue the plan for discharge to the nursing home. The vascular consultant disagreed. They restarted the IV fluids. She's not drinking, so she needs fluids. Okay, very simple, black and white. Not drinking, needs fluids. So what do you do next?
Have a conversation with the vascular consultant about what they're expecting out of this.
Well, they're not drinking, so they need fluids. Yeah, essentially what he needed was me to write in the notes to stop the fluids, to take responsibility for that decision. And once I'd done that, okay. And actually very happy to get a patient out of hospital. They weren't going to operate on her. So surgeons never want hospital. Patients in hospital are not going to operate on them. So anything you do to take them over, move them out, discharge them is fine. But in the meantime, they can't die while they're in hospital because I need to give them fluids. So it's really interesting kind of, to think through how you plan that and what you do about it. Okay, so that was what we did. Do you want another one or you had enough?
Can I ask a question about patients who are on insulin?
Yes.
And we are like stopping or rationalizing the medications and they're like not eating well, just like in her condition. What do you do with insulin?
Okay, so there are some diabetes at the end of life guidelines. I think that's what it's called, diabetes at the end of life care in diabetes, something like that. Anyway, from Diabetes UK, so official guidance is out there. And there's various different flow charts for different circumstances and so on. Basically, what you do is you simplify. So if they are on tablets, then they probably don't need their tablets anymore, and you can stop them. and reduce the frequency of checking BMs, and probably don't worry about it too much. What will happen is that the BMs will naturally sort of come down if they're not eating. If they are on insulin, often people are on mixed type regimes or short-acting or long-acting, mixed regimes, sometimes with tablets as well. So again, simplify, get rid of the tablets. And with their insulin, what you should do, if they're insulin dependent, whether they're type 1 or type 2, but when they're dependent on insulin, you look to convert it all into a long-acting, once daily dose of insulin. Short-acting insulins have no role if you're not eating. Okay, so they cover you through meal times. You have a dose, you don't eat anything, then your BM drops and you end up with hypos. What you really need to avoid is hypos. Okay, no worse. Running blood sugar is a bit high, 10 to 15, even up to 20. Not going to do them any harm. It's not going to change in there, in the short term. If people deteriorate and die, and then you don't need to worry about long-term complications. So move over to a once daily long-acting insulin, usually at a reduced dose because they won't need as much, and then titrate it up or down, like 20% or whatever, with monitoring a once daily BM. And if the BM starts to go up, then increase their insulin. If the BM's on the low side or in the sort of low teens or single figures, then you want to be careful that they're not drifting down to drop the insulin down a bit further. That's what you would normally aim to do. It's simplify. Okay.
Can I ask a quick question about respectful?
Yes.
I have heard, I think once or twice, someone say that you're not allowed to write not for readmission to hospital on a respectful.
Okay.
Is that true?
That's a real shame if I'm not allowed to write it, because I write that all the time.
Yeah, that's what I
Yeah. I'm allowed to write it. It depends on the circumstances, I guess. So the question, if people are still listening in, is on a respect form, are you allowed to write not for readmission to hospital? I don't think you're allowed to write that I'm saying they can't come back into hospital, because I don't think we have a lock on the front door. Hospitals aren't just about surgery and active treatment. They're also about care. We also have nursing staff. We have more nurses than doctors, and they look after people and sort of care for them. And that shouldn't be underestimated. That is really important for people who are dying and need to be looked after. And here might not be your first choice for that, but it's not an inappropriate place to look after them. And if that's their choice, or if that's where they end up and they want to be here, then we should be able to look after them. But what's really important is if a patient doesn't want to come back into hospital, that we're really clear on that. So if a patient says to you, and they will only do so if you ask them, but sometimes we need to have that conversation. But if they're really clear that they want to go out home or to a care home or to their nursing home or to a hospice or wherever, and they don't want to be readmitted to hospital, they want to be looked after out of hospital. And often people are saying, I hated it in hospital, I don't want to be here, I just want to get out. Then we need to be really clear that they're not for readmission. It's entirely appropriate to say they're not to readmission, but you should put in the wishes bit, box 3, that the patient doesn't want to be readmitted into hospital. What they want to avoid is being in hospital. What they want is to die, their preferred place of care, which is home or wherever. So entirely reasonable for you, and it should be countersigned by a consultant when you're in hospital anyway, but entirely reasonable for you to write this, what the patient wants, and to be really clear that they're not for readmission to hospital. What you shouldn't do is say, I don't think they should come back in, I don't want to treat them anymore, without discussing it with them. However, even if you've discussed it with them, we've got to be really clear what is it the hospital are offering. And if it is just care, that might be better managed elsewhere. So in terms of patient satisfaction, the best satisfaction, or for family satisfaction after somebody's died in bereavement surveys, is actually for nursing homes. Nursing homes do really well. Hospices do next. And then in their own home, and the places that do worst are acute hospitals, because we can't stop the junior doctor coming in the middle of the night starting IV antibiotics again. So, we need to be, here isn't the best place, and I wouldn't want somebody to be in hospital for end-of-life care if we can avoid it, if there are other places that they could be and they're well enough to move. Often people stay here because they're not well enough to move, but if they are, we should make every endeavour to move them if that's what they would want, or if we've got a better option for them. So if discussing with somebody whether they want to come back into hospital, I would outline what we can manage in the community. If they're going home, but they struggle at home, the backup plan might be to go to the hospice or a community bed, community hospital, rather than come back to an acute busy hospital ward. So I think it's entirely reasonable to write those things, but what we shouldn't be writing is, I don't think they can come back, I'm putting a lock on the front door so they can't come back. That you've got to be really careful about. But yeah, I would absolutely say it's entirely appropriate to write that's not what they want or not appropriate for readmission. As long as we're clear that we've done it properly. Okay. All right. I think we've probably come to the end of this, so let's leave it there and I'll let you all off. Okay. I'll save those for another day because there's some quite good ones in there, but I think they wanted me to cover the whole of palliative care within 2 hours. It's quite difficult to manage that. Right, for those of you who are still here, I will say thank you very much for listening in. I hope there's somebody behind those dots. You don't always know, but hopefully there's somebody still there. But I wish you all the best and let you get off. So thank you very much for coming.
Okay, thank you.
Thank you very much. Thank you.
Thank you.
All right.
Could you resend the email?